Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good morning. So everyone's okay so far? Okay, now why I choose to deliver this temporal bone tumor? This is because one of the important long case that you need to prepare is management of squamous cell carcinoma of the temporal bone. But in order to cover this topic, I include the management of ear and temporal bone tumor. So why I put this graph or figure is to see that we need to follow the ICD-10 codes if let's say you want to give a diagnosis. When you look at number 3 here, it's considered as malignant tumor, and this is the one that coded by WHO. So it can vary between the adenoma of the ceruminous until the squamous cell carcinoma of the temporal bone, and it also include the meningioma and vestibular schwannoma. Okay, so this is based on the histology of tumor of the ear and the temporal bone. Okay, so when you ask to deliver a certain topic, you should look at the definition. So there is also important that everyone knows regarding the international collaborations on cancer reporting, because the Indonesia may present their series based on their university or their hospital, but we should look at the international collaborations on cancer reporting. And why this is important: when you deal with the temporal bone tumor, you deal with the functional, which is hearing, as well as balance, as well as cosmetic. And when you want to do the operation, you need to have the radiological oncological section. So my presentation basically on this paper, the squamous cell carcinoma of the asna auditory canal and temporal bone, an update. So it's published in 2018. So the temporal bone malignancy is divided into primary and secondary. So when you have primary, it is not as a skin in origin, i.e. it is not melanoma or basal cell carcinoma of the skin. This is temporal bone malignancy, primary, arising from the external ear canal, middle ear, or extend to the inner ear. The secondary can be either, you look here, can be breast, lung, prostate, skin, cervix, liver, brain, and oral cavity. And I also go through, there's one patient, 60-year-old Indian lady, presented with otalgia, and when the surgeons examined, this patient had follicular carcinoma extend or metastasize to the temporal bone. So you need also to remember this. So this is not common. This is not common because it accounts only 0.2% of all tumor of head and neck. And as I mentioned before, it can arise from external ear canal or from the middle ear. What are the risk factors? The risk factor is common, which is you deal with a lot of patients with a persistent discharging ear for many years. So that's also one of the risk factors. Another one is regarding the radiotherapy. For example, patient completed radiotherapy for NPC, or patient has exposure to UV radiations. And what are the presentations of the patient? The presentation of the patients is straightforward. Most of the patients come with otalgia and blood-stained ear discharge. If let's say it's occurred in elderly patient, you should think that this could be squamous cell carcinoma until proven otherwise. Especially when the otoscopy shows there is a small swelling or oral polyp. And they also can present with the facial palsy, hearing loss, tinnitus, paralytic mass, or sometimes they can present with a symptom suggestive of the involvement of the intracranial. So when you examine the patient, you look at the patient general condition, whether the patient is pale, thin, ill-looking, and when you see, you can see that either like this. So this patient is 43-year-old Malay lady without any risk factor having this tumor. So when we examine the patient, we found out that the epicenter is from the temporal bone. So this is temporal bone carcinoma, extend to the parotid gland and also extend posteriorly to the brain. And it also showed that this patient has extension to the multiple cervical lymph nodes. So this patient, remember the 81-year-old Chinese lady? So this patient has extensive tumor. So whether this patient having a basal cell carcinoma of the temporal bone, because you can say this is roll over, or this patient has squamous cell carcinoma of the skin. So you need to ask the history first. So when was the first swelling noted? Is it from the post-auricular area? If let's say it's from post-auricular area and it's extend to the temporal bone, so this is secondary tumor. Okay. So when you see the ear, before you see the ear, you look at the patient, whether the patient had nystagmus and whether this patient had multiple cervical lymph nodes and the parietic swelling. Then you look at the ear, you can see there is a mass arising from, this is from the posterior wall of the EAC, and you can see the skin over the area also swollen and inflamed. So now the question is, when I should take a biopsy? Is it now during the first visit to the clinic? So it depends on your working diagnosis. So that's why everyone as a doctor need to have a very critical thinking about the provisional diagnosis. If let's say your provisional diagnosis is squamous cell carcinoma of the temporal bone, you should do a biopsy at the first visit. Sometimes the MOs or the registrar say that, oh, I will give a empirical antibiotic augmentin therapy A drop, wait another 2 weeks and see. But if let's say you think that this is SCC of the temporal bone, you should take biopsy. And you should also treat with the antibiotic, no problem, because patient may come with the SCC of the temporal bone with a otitis externa. So now, this is also one of the picture from the manuscript. They say that sometimes you are not too sure whether this patient having necrotizing otitis externa or diffuse otitis externa, or the patient has oral polyp. So this is the differential diagnosis. So when you have history, you examine the patient, you give professional diagnosis, you need to stand by at least 3 differential diagnoses. So don't say that this patient had adenocarcinoma. How many patients come with the adenocarcinoma? But this list inside the textbook, you should highlight this patient could have skull-base osteomyelitis or osteoradionecrosis, or this patient had necrotizing otitis externa because he is elderly and he's presented with the pain and there's a presence of drainage tissue. Okay, so the take-home message is, while doing the clerking, while doing the physical examination, prepare provisional differential diagnosis with the reason. Okay, with the reason. So the investigation that everyone should request is pure tone audiometry. Before that, you need to do a twinning fork test. You need to have a deep biopsy. Why I say that deep biopsy? Sometimes the MOs scared to do a deep biopsy because patients, they scared that there will be a bleeding. So if let's say you think there's a possibility of bleeding, what you should do? You should arrange urgent high resolution CT scan of the temporal bone on the same day, and 2 days later, you ask the patient to come back again, review the CT scan with your specialist and take biopsy. Okay. If let's say when you do a probing, you should do probing, right? When there's oral polyp, when you do a probing, look at where is the origin. The origin is broad base and there's a contact bleeding. You're afraid of bleeding. What you should do, you should put amla cream, try to pack it for about 20 minutes, prepare trichloroacetic acid, then we can take a biopsy. Normally it's not torrential bleeding. Don't take biopsy in the case of the first patient that I showed earlier. Okay, that one can have a torrential bleeding. Then you should request HRCT of the temporal bone with the contrast from the base of skull until lower part of the neck to assess the extension, the site, the involvement, and to help you in terms of staging. Then you may or may not request the MRI. When you decide for MRI, maybe Dr. Razak, when you decide to do MRI, okay, elaborate more. Okay. Okay, what else? So you should think that your temporal bone here anteriorly temporomandibular joint, superiorly is the brain, inferiorly is parietic gland, posteriorly you want to assess whether this patient had further involvement of the posterior canal fossa. Okay, so you look at, you try to think about your ear, and you may request for the systemic workup. Then when you decide to do ultrasounds of the liver, so if let's say patient is T4, I give you T4, you should do first chest x-ray because they cannot skip the lung and goes to the liver. So you should go for the chest x-ray. But if let's say patient have T4 and you want to embark on the surgical intervention, aim for the therapeutic or curative, then you should do ultrasound of the liver, at least one. So before you do ultrasound of the liver, you should do the liver function test. Derangement of liver function test, you should do the ultrasounds of the abdomen and liver. So now CT scan. So when you want to do the CT scan, again, you will also want to look whether this patient has a squamous cell carcinoma or cholesterol granuloma or cholesteatoma. So what are the features of squamous cell carcinoma of the temporal bone, Dr. Intan?
Have bony erosion.
Okay, good.
Involving of the surrounding structure, which is we mentioned just now, anterior, posterior.
Okay.
And it enhances on HRCT, contrasted CT.
Okay. So if let's say you have an involvement of lymph nodes, I'm sure that you think this is malignancy, especially when there is a necrotic center. The size and the shape of the lymph node also important. So that's why when I think about this program, I think we should include the radiologist to be here. Then Dr. Q will be present 2 lectures tomorrow. Okay, we change to tomorrow. So in this case, this is to look in detail in terms of the, you can see this is condyle of the temporomandibular joint. So initially, when the patient has a tumor, there is involvement of the soft tissue inside, but when patient defaulted follow-up, so you can see there's further involvement of the condyle of the temporal bone. Condyle of temporomandibular joint, sorry, of the mandible, So this is the CT scan. So now, maybe doctors at the back, okay, maybe the one that blue press. So can you try to read this axial cut of this CT scan? So in the exam, you should see that this one and this one different, right? Okay, so don't be panic. So in the exam, don't be panic. There is a soft tissue density occupying the whole temporal bone, which extends to the posterior canal fossa. So it extends anteriorly. So then they will ask you, okay, what could be the possible diagnosis of this patient? If then they will give the history. This patient presented with so and so. So in other words, you can say that this soft tissue density, destructive, I cannot visualize any air cell, could be malignancy. Okay, then we can further discuss. Okay, so this is one of the initial case write-up done by Miss Norizan. Okay, so you can see that this patient is an Indonesian lady presented to us with a many years history of discharging ear, and now she presented with history of a mass inside the external ear canal extend to the post-auricular area. So in this case, this patient was investigated with the HRCT of the temporal bone, but also we proceed to the MRI. Okay, this patient's not having any treatment, so we send back this patient to Indonesia. So MRI may distinguish between benign and malignant. So when you have this one, okay, loss of signal on T2 weighted image and T1 weighted image, and contrast enhancement are typical finding in SCC. In contrast, when you have hyperintensity on T2. T2 is water, and diffusion weighted image is possibly cholesteatoma. Okay. So why we need to have the MRI? So this one, everyone need to know to draw the skull axial cut. So you can see the extension, and you can see this is axial, this is coronal cut. So if let's say it's involved into the deep part of the lymph nodes in the parotid gland, intraparotid lymph nodes, so at least you need to do a superficial parotidectomy. That's why you need to do the MRI. So 10 to 20% of cases present with cervical lymph nodes, and when it extends to anterior, it can having a pre-auricular lymph nodes. Extend to inferior can have the jugular digastric lymph node, and they also can present with the retropharyngeal lymph node if let's say it's extend medially. Okay, so Pittsburgh classification. This one cannot be run from remembering. So it's straightforward lah. Basically, T1 is limited to the EAC without bone erosion. T2 tumor limited to EAC with 0.5 cm soft tissue extension. T3 when the erosion is less than 0.5 soft tissue, and there is also T4 tumor eroding more than 0.5 cm. So in other words, when you have patient with squamous cell carcinoma of the temporal bone, you need to do a staging. So stage 1 T1 N0 MX MO. T2 is T2 N0 MO. Stage 3 T3 NO M0 or T1 N1 M0. Stage 4 is T4 N0 MO and T2 to T4 with N1 or M0 or T1 any N or MI M1. So surgical indication, this is very straightforward. T1, some of the textbooks say they white excision. You also can look at the literature, they say that sleeve resection is the same. T2 lateral temporal bone resection plus post-operative radiation considered as a subtotal superficial parotidectomy. T3 is subtotal bone resection or total bone resection. So normally we will do in T3 or T2 or T1. Rarely we do an operation in T4. Rarely. So planning of surgical approach. So how you want to plan for the surgical approach, the size and the extension. So in other words, what are the factors contribute to your planning? Size and extension. This is applied to not only SCC, can also apply to all the tumor, head and neck cancer. So involvement of the parotid gland, temporomandibular joint, lymph nodes, functional function, skin incision and KIB flap reconstruction. Why? Because you may or may not remove the pinna. So if let's say you want to do a total pinectomy, you remove the pinna, how you want to reconstruct? You want to put a split skin graft? Cannot take. So you need to have a big muscle to apply and to reconstruct the defect. And whether the patient need to have a post-operative radiation therapy, and it must include the multidisciplinary approach. Okay. So interestingly, when you look at here, so why pathology is important? Because this one moderately differentiated, poorly differentiated. This is basal cell carcinoma of the temporal bone, and this is adenocystic. So when you have patient come with a facial nerve palsy, the swelling inside the external ear canal is very small. Then you should think, is it squamous cell carcinoma or adenocystic carcinoma? Because the typical of the adenocystic carcinoma is perineural spread. So in other words, you can give this argument with your lecturers. So this is adenocystic CA. So compared with the other benign lesion, this is cholesterol granuloma and this is cholesteatoma. So treatment wise, so this is considered as this one. You can see this lateral temporal bone resection. Remove the skin as well as the cartilage from the outer part of the EAC until the middle wall of the middle ear. So this is a lateral temporal bone resection. You remove the whole temporal bone, this is total temporal bone resection. In between, you can call it subtotal temporal bone resection. So when you plan for patients durisami, so this is the incision. So we want to sacrifice the ear, so we do a radical mastoid surgery, remove. So we remove and we preserve whatever the patient has. Patient preoperatively already have the facial nerve palsy, and you remove this. So in a sleeve resection, it's the same. You can see the difference is, you can see this is the TM. So if let's say you do a sleeve resection until this part, also can call sleeve resection, or you can do a wide excision. So this is in T1. So if let's say it goes until the middle wall of the middle ear, it's considered as a lateral temporal bone resection, but you need to blind sac the EAC. You need to close the EAC. So this is considered as lateral temporal bone resection. So this is considered as subtotal. So how about the radiation therapy? Is it one of the first choice? So one of the mistake that has been done in other parts of this country is patient is elderly patient. Elderly patient present to ENT specialist in private, straight away go for the radiation therapy. This is wrong. It is wrong. So you can imagine patient is present with early. Elderly patient is okay, no morbidity, still operable. You should embark to the surgery. So you cannot say that, oh, elderly patient, small tumor, go for radiation therapy, because it's not sensitive. So you should go for surgery. So the role is very limited, and it is for adjuvant radiation therapy when there is a cervical positive patient. So you go for surgery, then you go for radiation therapy. Then you can also combine with others primary resection. And if the patient is unfit for surgery, then you can also go for radiation therapy. This is not for curative. This is for to slow down the progress or to stop the bleeding. Like the one that I showed to you earlier, a patient, she had history of 3 hemostatic radiation therapy just to stop the bleeding. Or in patient with unresectable disease. Or we can give a palliation chemoradiation therapy if let's say the patient may offer. So you can give chemoradiation if let's say patient has. I hope that everyone, when you have patient during the combined onco, remember the case. Remember my case and Miss Dina case, a patient, elderly patient who has CA stomach, presented with swelling over the pain over the pinna, and then we do HRCT of the temporal bone, and this patient seems to have a metastasis from the CA stomach, which is already cured, now having a second primary in the temporal bone. Do you want to do a resection or not? So of course we have a discussion. So in this case, we don't want to do any destructive procedure because patient elderly. Then we say that we can go for a palliative chemoradiation. Can be done. Can be offered. But not in a patient who are first come and see you. You say that, oh, this is chemoradiation. No, cannot. So other option. If let's say a patient refuse to do a penectomy, patient refuse to do a blind sac of the EAC, but patient agree for operation, then we can do a radical mastoidectomy, post-op radiation therapy. Okay, post-op radiation therapy. If let's say the tumor is big and you think that patient may benefit of having this surgery and a post-op radiation therapy, please proceed. So this happened to Makcik Cik Mina. Till now, she still survive. And the facial nerve also improve. The facial nerve functions improve. So I still follow up with her every 6 months. So now she having osteoradionecrosis of the temporal bone, but tolerable. The pain is tolerable. So this is how we do a radical mastectomy. We need to harvest a huge superficial temporary fascia. Why? Because this is the fascia which need to place over the bed of radical mastectomy, and the patient still have pinna with the mass or osteoradionecrosis deep, but patient's happy. So we just prolong the patient, not aim to have a curative. So now when you look at the patient, so this is the granulation tissue. Do you want to take a biopsy? No need to take a biopsy. We know that this is the tumor. Okay, what we know, we need to investigate in terms of the extension. So we just explain to the family members, explain to the patient that the aims now is not for curative intention. So treatment option. So you can see that if let's say you combine surgery with adjuvant radiation therapy, overall 5-year survival is 40 to 62%. Compared if let's say you embark on the radiation therapy. So this is combined approach. So this is algorithm that everyone to be registered in the brain, that straightforward. If let's say you have T1 wide excision or sleeve resection, T2, okay, you can do lateral temporal resection with or without superficial paratidectomy. Normally we are not going for superficial paratidectomy if let's say the parotid gland is not enlarged. If let's say there is intraparotid lymph node or the parotid gland is enlarged, you will do a superficial paratidectomy. If let's say the patient has T3, T4, you can either do a subtotal. Rarely we do for the total temporal resection. So how about the prognosis? I have another 10 minutes. Okay. The prognosis, early temporal bone tumor T1, T2 carry a good prognosis. I have 2 patients so far under my follow-up. Patient has successfully treated with lateral temporal bone resection post-op radiation therapy. So next 2 years, if let's say we need to host the exam, I can bring my patient who has a very extended C-shaped post-op plate incision, and you can see there is a blind sac of the ESC. Then I will ask what could be the surgery that has been performed in this patient. So 80 to 100% 5-year survival rate who had primary resection with or without adjuvant therapy. T3 and T4 lesions carry poor prognosis. 2-year survival rate is less than 40%. So what determines the poor prognosis? Then I will ask Azina, Prof. Marina call. Then Ilya.
High stage disease.
Okay.
Peritoneal ablation. Intracranial gestation. Involvement of the parotid gland.
Involvement of the parotid gland is not, because we know that the drainage of the temporal bone SCC is toward the intraparotid lymph nodes. Involvement of deep lobe of parotid, yes. Because if let's say involvement of deep lobe of parotid, the patients normally have a facial nerve palsy. Okay, what else?
Histologically poorly differentiated SCC.
Hmm?
Poorly differentiated SCC.
Okay, if let's say poorly differentiated SCC, poorly differentiated, normally it will be radiosensitive kan? But provided that we do a surgery first. Okay. What else?
M1 disease.
Hmm?
M1 disease.
Okay, of course. So positive margin. Remember, if let's say poor prognosis, positive margin is one of poor prognosis. Single modalities when you have T3, T4. Okay, how about PET scan in temporal bone carcinoma? Is it good or not to have PET scan? So this is based on the literature that I read before. The roles not been well evaluated. may be useful for surveillance or detections of nodal or distant metastasis disease. However, PET scan is unable to distinguish between inflammatory and malignant process and has poor spatial resolution for EAC neoplasm. So this is multi-center experience in temporal bone cancer surgery based on 89 cases published in 2017. So the important is margin status and extratemporal dissections spread. It is strongest independent predictors of survival and recurrence. So in other words, when you want to do operation, you need to have a good margin. Maybe you can also try to request for deal with the pathologist to see the margins. You send the margins to see whether it is have a good margins or not. Then another thing is that in SCC of the EAC, high rates of parotid involvement support adjuvant parotidectomy. Risk of recurrent T3, T4 support the role of adjuvant therapy. So now I mentioned that this is a management of ear and the temporal bone. So ear is include the tympanic membrane, right? So I wonder how they can get this isolated primary squamous cell carcinoma of the tympanic membrane. Normally, if let's say our patient present to us, not mainly with the tympanic membrane mass, so it extends to the external ear or to the middle ear. So they put here the risk factor is something. Here is exposure to radiation, the same HPV, tobacco, and diabetes, maybe of the immune system. So conclusion. So biopsy and radiological imaging remain the key of the management. Okay, early biopsy, early radiological imaging. Early diagnosis does not only decide on the extent of the surgery needed, but it also increase the treatment success rate. Risk of recurrence is high in T3 to T4 and it need the adjuvant therapy. And I would like to thank everyone. This is my contact number. Everyone can ask the opinion or email me any question. So I have 5 minutes for question and answer. Okay?
Prof, in each type of temporal bone resection, do we have to remember structures that we remove for exam purpose?
It is very straightforward. Straightforward means it's very easy. Okay, the structures, okay? So you just remember that in a lateral temporal bone resection, you remove the skin and the bone, including the mastoid hair cell, until the middle wall of the middle ear. You blind set the EAC. Finish. Okay, only 4 facts that you need to answer. In a total temporal bone resection, you remove the whole temporal bone. Then you can say that, what is the temporal bone structures? It consists of 5 parts of the temporal bone. Straightforward kan? Squamous part, semua tu. Okay. If let's say in between, subtotal temporal bone resection. If let's say you do, like for example, you need to drill the condyle of the temporomandibular joint, it's already considered as subtotal temporal bone resection. Okay.
Thank you, Prof.
Any other question?
Prof, just now in one of your patients you mentioned about perform radical temporal bone resection. That's
So that one is not in the textbook. The radical mastoidectomy. The question is again?
You mentioned your patient perform radical temporal bone resection.
Oh, not radical temporal bone resection. This is radical mastoidectomy. Sorry, radical mastoidectomy. So if let's say the patient presented with good functions of the facial nerve, okay, and supposed to be this patient has to go for the lateral temporal bone resection. Okay, my patient has a good facial nerve function, but the tumor is already extended towards the pinna. By right, if let's say I would like to go for oncological resection, I should remove the pinna itself. Okay? Because it's already, I cannot have a good margin to blind set the EAC. Then, at that particular patient, I do a radical mastectomy. I'm not doing a blind sec, but I send the patient for post-op radiation therapy. But don't mention inside the exam. This is only when your patient still operable. You should tally with your patient's needs. Okay. Thank you very much. If anything, you can ask later.